My name is Kelsey Staler, as she said previously. I am from Indiana University at Indianapolis, Indiana. And today I'm going to be presenting to you a recurrent metastatic lung mass with an unexpected origin. Okay, so by the end of today, I hope you guys will be able to evaluate the clinical and radiologic features of a metastatic disease, identify cytologic and histologic patterns guiding this diagnosis, and also discuss immunohistochemistry and molecular testing rules. So who's our patient? We have a 47-year-old female. She presented with a lung right lower lobe mass. She's HIV positive, she's a BMI of 77, she's hypertensive and pre-diabetic, and she also has primary hyperthyroidism. So this history there's a lot going on, as you can tell. But it's going to be a big thing when it comes to treatment for our patient, and we're going to keep in mind all of her history when it comes with clinical applications. Okay, so let's talk about the radiologic imaging. On imaging, we see multiple bilateral pulmonary nodules. The largest measures 3.4 centimeters in the right lower lobe. So I'm showing 3 examples here, but there were several scattered throughout both of the lungs. Because of its size and accessibility, the largest lesion was selected for sampling. This gave us the best chance of obtaining diagnostic material while also being the safest for our patient. Let's talk about the air-dried FNA. With this cytology, we can kind of see some cohesive clusters of tumor cells with some short peripheral branching. The architectural pattern immediately pointed us towards a basaloid process. It's subtle, but it's one of those clues that gives us a start on what we can start looking for. And then the pap stain is what really shines for this case, in my opinion. On the pap stain, we can see oval to round basaloid cells, high nuclear cytoplasm ratios, some fine powdery chromatin, and also smaller inconspicuous nucleoli. These findings also support that basaloid neoplasm structure, but at this stage, they're also not specific enough in order for us to make a definitive diagnosis. They tell us we're on the right track, but we still kind of keep going and see that architectural context or understand it. So this is where the cell block comes into play for us. The cell block gives us that architectural clarity. There's nests and islands at the bit of the cells. And bear with me while I zoom in for you guys so you can really appreciate it. Ooh, that's a little too far. Okay, perfect. So here we can kind of see a central zone of loosely arranged stellate reticulum-like cells. We're kind of looking right here. There's a peripheral palisading layer of columnar or cuboidal cells. And then right here at the bottom, there's reverse polarity with nuclei oriented away from the basement membrane. So this combination of features is really classic, and it leads us to the differential that I'm about to show you guys. Perfect. So our overall diagnosis ended up being a metastatic ameloblastoma. Now I know when I saw this diagnosis, I had no idea what this was. So a lot of research went into this case, but for you guys, how I'm going to explain this is a rare odontogenic tumor. That basically means it arises from tooth-forming tissues. And remember, we're in the lungs right now. In this patient's case, it metastasized from her jaw to her lungs. It's usually indolent and benign appearing, but the lungs are often the most common site that it metastasizes to. So what supported this diagnosis for our patient? Radiology, of course, that common jaw to lung, or it's not common, but that rare jaw to lung metastasis, those cohesive sheets of basaloid neoplastic cells, and also she had a previous history of ameloblastoma. So I just wanted to show a little fun, cute timeline in order to really understand this patient's disease process. She first occurred this disease at the age of 15, and then at the age of 31, and now at the age of 47. So this is her 3rd reoccurrence of this disease. Over the years, she's also gone multiple jaw reconstructions, and she's also gone several lung wedge resections. Chemotherapy treatment she's been through twice, and in attempts to control her disease, all of these things just kept adding up for her treatment. Her clinical journey has definitely been very, very long and very complicated for our patient. So let's talk about the immunostaining and the genomic testing that was done for her. She did have HER2 positivity, and she had a very, very high PD-L1 expression. This basically means that she is eligible for Herceptin and Keytruda treatments. The high PD-L1 expression is really, really meaningful because this opens doors to immunotherapy options for this patient, especially in tumors with limited conventional treatment like this one. BRAF was also a mutation that was found, but it was the only one that was positive in her genomic report. And then we're going to go through the tumor mutational burden that was on this this report. So this is a big part of the report that I found really interesting. This low tumor mutational burden really shows that this is really a benign indolent appearing tumor. It gives like that biology that really sets this thing apart. So let's talk about the statistics of this disease. 0.5 in 1 million people develop ameloblastoma, and then 2% of ameloblastomas are actually malignant, or they appear malignant and act malignant. This makes up less than 1% of all tumor and cysts of the jawbone, so it is very rare. This rarity is really just what sets us apart for this tumor. And then we're going to go to her current state. So today her management is primarily palliative with a major focus on weight loss in order to go through surgery. She continues CT surveillance every 4 to 6 months. That is a last resort option for her because undergoing chemotherapy for a third time would be not the best option, obviously. But an important part of her story is really how this recurrence was found. During workup for her primary hyperthyroidism, they found these lung nodules. These lung lesions were ultimately confirmed as her recurrent ameloblastoma, but the thyroid nodules that were found along with it were benign. Although 4 months later, more workup was done, and she was actually diagnosed with papillary carcinoma along with this malignancy. So this means our patient now has 2 seemingly unrelated malignancies, but that BRAF mutation was found in ameloblastoma can also be the same pathway associated with papillary thyroid carcinoma. So we gotta keep that in mind going forward. And I really wanted to show you guys this papillary thyroid carcinoma because it really is just a perfect example of what it looks like. I know that air dried, you can just see that there's no color. And then with the pap stain, you can really see those papillary formations and those shaped cells. And then they also did TTF1 testing. And the TTF1 immunostaining confirmed that this was indeed a thyroid carcinoma and it was not from her primary jaw to lung cancer. So what does this all mean for our patient? She now has 2 seemingly unrelated primary malignancies. And because the thyroid carcinoma diagnosis is so new, we truly don't know how this influences her overall treatment strategies. The BRAF mutation was found in the ameloblastoma, but they haven't done workup for the thyroid enough yet to understand if that's also what's going on here. Will her care be palliative, or will the clinicians choose to treat one or both the tumors at the same time? This case may leave us more questions than answers, but I really want to share with you today because it's a great example of how history doesn't always impact the diagnoses that we see, because she now has 2 malignancies. So here's my references for the case. And then I would really love to thank everybody who helped me with this: Barbara Frame, Joshua Howell, Dr. Omer Sigi, Michael Vornovich, and Kimberly Brown for their guidance and support, and also the ASCT for allowing me to present this case today. Thank you.
Good afternoon, ladies and gentlemen. My name is Cassandra Moss, and I'm part of the Roswell Park and Damon University 4+1 program. And today I'll be presenting my interesting case called An Illusion Within an Effusion. In this case, I will be proving the objectives of using the clinical history and the symptoms of the patient to analyze what procedures or specimen collection needs to be completed. I'll be using the clinical history, radiology reports, and the gross description to accurately create a list of potential malignancies. I will then be obtaining a cytomorphological description of the malignancy present in our patient. And then I'll be using immunohistochemical stains and fluorescent in situ hybridization to confirm the diagnosis. And once the diagnosis is confirmed, I will be explaining the diagnosis and the malignancy and explaining the details such as the epidemiology, the genetics, and the treatments. So let's get started by looking at the patient's presentation. We have a 9-year-old female who came in with the symptoms of shortness of breath, weakness, and tingling in her arms and legs. She had a prior clinical history of pain, fatigue, and weight loss, and as a result of her symptoms and the clinical history, she was sent in for a CT scan. The results of the CT scan found that there was a left parietal mass located on the T7 portion through the T9 portion of her vertebra. They also found a right parietal mass located on the T8 portion of her vertebra. Due to these radiological findings, she was then sent in for a spinal biopsy. One piece of specimen was frozen and collected, and that will be used for a fish analysis that we'll discuss later on. And the other 2 pieces of specimen were collected from the left parietal mass, one from the T7 region and one from the T9 region. And a cytology specimen was also collected, and it contained 25 milliliters of bloody pleural effusion that was sent into cytopathology. So now that we know her gross description, we know the clinical history, her symptoms, and her age range, we can narrow down the types of malignancies that we might see present in this case. So first we have a neuroblastoma, which is a cancer of the nerve cells. Then we have an alveolar rhabdomyosarcoma, ARMS, which is a cancer of the skeletal muscle cells. Then we have a Ewing sarcoma, which is a cancer of the soft bone and tissue. Then we have a desmoplastic small round cell tumor, DSRCT, which is a cancer of the mesenchymal origin. Then we have a Wilms tumor, which is a cancer of a kidney. And then we have a non-Hodgkin's lymphoma, which is cancers of lymph nodes. And why these 6 specific malignancies were chosen is due to the tumor type. So they all share a type of tumor, which is soft tissue tumor, which is present in our patient. Another one is due to the location. So all of them can either develop and or metastasize in the spinal cord where the tumor was found in our patient. Then we have the patient's age. So all these malignancies are predominantly found in children, which is important because our patient was a child. And then finally, our symptoms. So some of the symptoms, if not all the symptoms present in our patient, are also common symptoms you can see in this malignancy. So now it's time to look at the cytomorphological profile within our case. So if you guys would like to, you guys can take out your phones and you guys can take this QR code to allow you to see the pap stain of here, and we can go over the cytomorphological profile. So in the pap stain, we're specifically looking at the nuclear features within this case. And if we look at figure A, we can see that there's smooth nuclear membranes present within our case. And as we zoom in on the magnification shown in figure B, we can see that there's dark and fine chromatin present. And finally, in image C, we can see that there's small nucleoli present, about 1 to 3 nucleoli depending on the cell. So now we go to our H&E stain. And in our H&E stain, we can see the overall architecture of the cell. So that means seeing the type of cells that we're working with as well as the background. So if you look at image B, we can see that we're working with some small round cells present in our case. And then we can look at image C, we can see that there's a necrotic background, and mitosis may be present depending on what areas of the cell that you're looking at. And then we look at our right Giemsa stain. So our right Giemsa allows us to see the architecture of this case. And that means that we get to see the cytoplasm presence, the cell sizes, as well as the cell structure. So what we found is that there was thin, infillamorphic, and or clear cytoplasm present in our case. All the cells shared similar sizes. And then there was a discohesive single cell architecture with potential rosette formations. So now that we know the cytomorphological profile within our case, we can compare our pleural fusion to our potential malignancies that I stated before. So let's start. Now looking at our case in DSRCT, a clear feature of DSRCT is that nuclear molding and that clustering that you guys see in the bottom photo, and that was not found in our case. So that actually takes DSRCT out of our potential malignancy race. So now, we look at our case in a Wilms tumor. And as we can see on the image on the bottom, we can see that Wilms tumor has a triphasic pattern. That triphasic pattern contains a blastemal component, an epithelial component, and a stromal component. And this triphasic pattern was not found in our case, thus Xing Wilms tumor out of our potential malignancy list. And then we look at our case in a non-Hodgkin's lymphoma. And what we can see in the non-Hodgkin's lymphoma is that they have an intermediate cell type, and they almost have a naked nuclei look due to the little cytoplasm that is present. And that is very different from our case, which shows that small round cell structure as well as that abundant cytoplasm. So that exits non-Hodgkin's lymphoma out of our potential malignancies. But let's keep looking. So now we see our case in the neuroblastoma. So actually, when you look at both the cases, you can see that they both have eosinophilic cytoplasm and that round small cell size. So that actually keeps neuroblastoma in our potential malignancy list. Now looking at a Ewing sarcoma in our case, we can see that they both share that small round cell size as well as that dark and fine chromatin pattern. So that's also going to keep Ewing sarcoma in our potential malignancy list. And then we look at rhabdomyosarcoma in our case, and what we found is that it has a round small cell size, which keeps rhabdo in our potential malignancy list. So what does that mean? This narrows down our 6 potential malignancies into 3, which is a neuroblastoma, an alveolar rhabdomyosarcoma, and a Ewing sarcoma. So in order to find out what we're looking for, we conducted an immunohistochemistry panel. What we found is that in our specific case, CD99 was positive, PAS was positive, PASD was positive, but there was a partial positive for S100. But our case was negative for CD56, Desmond, and MyoD1. So now that we know the information in our panel, we can compare it to the next 3 malignancies that are potentials and narrow it down to the exact one we're looking for. So first, let's start with neuroblastoma. Neuroblastoma's IHGs show that it's positive for CD56 and negative for CD99, which does not match the immunohistochemical panel of our case, thus exiting out of our potential malignancies. Now looking at rhabdomyosarcoma, even though rhabdo can stain positive for CD99, it also stained positive for Desmond C and MyoD1, and in our case, it did not stain positive for either two of these IHCs, thus removing it from our potential malignancy list. And finally, we're going to take a quick look at a Ewing sarcoma, and what we can see is that in our case, and Ewing sarcoma, it stained positive for CD99, PAS, and PASD, which confirms that our diagnosis is a Ewing sarcoma. And actually, because I want to give a little bit of IHC information, because I actually find this interesting, CD99 stains positive for tumor cells with a high intracytoplasmic glycogen presence, and that's important because a Ewing sarcoma, that thin, clear, amphibomorphic cytoplasm that you see, is due to the fact of that high glycogen presence that's present in the Ewing sarcoma. And that's also important for PAS, or PAS, because PAS stains for carbohydrates, and glycogen being one of those carbohydrates it would stain for. So now, to confirm the diagnosis, if you didn't believe me already, we did a FISH analysis, and you can see that the EWSR1 probe, when it was applied to 400 nuclei, it showed a split of 380 out of the 400 cells, showing a 95% accuracy of the diagnosis being a Ewing sarcoma. So now that we know what's a Ewing sarcoma, it's time to learn more about this malignancy, because it's an extremely rare cancer that makes up about 1% of all cancers. It approximately affects about 200 children and teens in the United States each year, and has a slight male predominance, being about 60% male and 40% female. And the patient population is around the ages of 0 to 20 years old, with the mean age being about 3.2 years. The most common region of development is in the lower limb, and it predominantly affects non-Hispanic white people and Native Americans. And once localized, a Ewing sarcoma has a pretty good prognosis, having a 5-year survival rate about 81 to 82%. But once it does metastasize, that survival rate does decrease to about 39 to 41%. The morphology of Ewing sarcoma shows a monomorphic architecture with round sheets and or single cells. Its nuclei can be round to oval, smooth nuclear contours, small nucleoli, and dispersed chromatin. And its cytoplasm is usually clear to a pale eosinophilic color. Now, the genetics of Ewing sarcoma. I find this very cool, so hold on. So Ewing sarcoma, what happens during this situation is that the EWSR1 gene in chromosome 22 and the FLI4 gene in chromosome 11 fuse together during Ewing sarcoma. So what does that mean? In your normal cells, when they're not fused together, they actually have the same function even though they work separately, and that function is to regulate transcription. That regulated transcription then regulates cell proliferation and removes all abnormal cells via apoptosis. But when a Ewing sarcoma happens and that fusing of those genes happen, what happens is there's unregulated transcription, which then leads to cell proliferation with cell abnormalities, so you get those tumor cells that are able to grow and then metastasize. So for our treatments and follow-up, unfortunately for this patient, she unfortunately did expire, and we did not know all the treatments that were used, but we do know the average treatments that are used in a Ewing sarcoma, so they can be applicable to this case. So the two treatments that we're looking at here are chemotherapy and radiation, and their function is to kill the cancer cells, which to stop them from dividing. We have surgery, which will remove all the cancerous material, and finally we have stem cell transplant, which will basically be removing all the stem cells from the patient. They will go through either radiation, chemotherapy, or surgery to remove all the cancerous material, and then they will infuse those stem cells back in via infusion. And a follow-up would be conducted with the patient care provider to make sure that these treatments are working or if other methods need to be taken. And before I end this off, I would just like to thank my education coordinator, Rebecca Kibler, my cytology supervisor, Allison Kidd, and my program director, Donna Russell, for teaching me about the amazing world of cytology. And finally, I'd like to thank the ASCT for giving me this opportunity to present. Here are my references, and thank you so much. If you guys have any questions, please feel free to ask.
All right, our final presenter today is Betty Perozzo from the University of Nebraska Medical Center.
Well, hello everyone, my name is Betty. I am a diagnostic cytology student at the University of Nebraska Medical Center. Today I'm presenting a case of endoscopic ultrasound-guided final aspiration diagnosis of a late retroperitoneal granulosa cell tumor recurrence. I know that's a very long title, but hopefully after today's presentation, you're going to be able to list the general criteria of this entity, recognize the key cytomorphologic features of this tumor, correlate immunohistochemical findings with diagnostic interpretation, and discuss the role of tumor markers in disease monitoring. So this is a 47-year-old female patient with a history of adult granulosa cell tumor, initially diagnosed in 2006 and treated with a right salpingoforectomy. In 2011, she developed a recurrence, which was managed with a left salpingoforectomy, a total abdominal hysterectomy, and chemotherapy. She now presents more than a decade later with elevated inhibin B levels and an enlarged retroperitoneal lymph node. On imaging, this axial CT scan shows this enlarged 3.4 enlarged retroperitoneal lymph node that is located anterior to the inferior vena cava. So due to the retroperitoneal location of the tumor, endoscopic ultrasound-guided final aspiration was selected as a minimally invasive approach to obtain diagnostic material. And here we have a picture of the tumor taken during the endoscopic ultrasound-guided FMA. So the obtained material was processed for cytologic evaluation, which was, we obtained material for Deathwick stain smears, Papa Nicolau smears, and a cell block stained with H&E. So starting with the Deathwick, at low power, we see these loose clusters of cuboidal to polygonal shaped cells. In the background, we see numerous single cells and naked nuclei, and then these bright magenta areas are some metachromatic stromal material. At higher power, we found this occasional rosette-like arrangement. We can see that the cells are arranged surrounding this eosinophilic stromal material in the center. Now, with Papa Nicolau staining, we're going to be able to describe nuclear details. So we can see here that the tumor cells have a round to oval nuclei. They have finely granular chromatin, a small visible nucleoli, and more importantly, some of the cells, like this one right here and this one right here, there are more, they show these nuclear groups that give them a coffee bean appearance. The cytoplasm is kind of like indistinct and it's variable in amount. The cell block shows similar features where we see the tumor cells, they maintain that round to oval nuclei with occasional nuclear groups in pale chromatin. So now I would like to move on to diagnostic considerations and challenges. Given the patient's history of an adult granulosa cell tumor, a recurrence of this sex-core stromal tumor was an important consideration in this case. Here, on the left side, we have a picture of a granulosa cell tumor that shows a loose cluster of small to medium-sized cells with pale chromatin and prominent nucleoli. On the other side of the slide, we have a picture of our specimen that shows similar features. However, given the anatomic location of the tumor and also some of the cytomorphologic features, gastrointestinal stromal tumor was part of the differential diagnosis. And me as a student, when I think about GIST, my mind goes to spindle cells, stomach, right? But the epithelioid and myxoid variant, they can appear in atypical intra-abdominal locations, and the cytomorphologic features, as we see here, show cuboidal to polygonal shaped cells with round nuclei, and then in the background we see this myxoid stroma. Then on the other side of the slide we have a picture of our specimen, a Deathwick stain smear, that shows similar features. So we see, again, cuboidal to polygonal shaped cells, and in the background we see this metachromatic stromal material. So some of the challenges in this case were related to the limited tissue sample, and that happens sometimes, and also the overlapping cytomorphologic features in a deep retroperitoneal location. And again, due to limited tissue sampling, a targeted panel of immunohistochemical stains was used. And then the cells were positive for SF1, which is a very sensitive marker for sex-core stromal tumors. They were also positive for inhibin A, and then they showed patchy positivity for calprotectin. On the other hand, the cells were negative for DOC1 and CD117, arguing against the GIST diagnosis. So now putting everything together, patient's history, cytomorphologic features, and immunohistochemical stains, the findings are consistent with a granulosa cell tumor. This was confirmed with a surgical resection of the tumor that showed a metastatic granulosa cell tumor with necrosis. This histology section right here shows a diffuse pattern of cells with annular nuclei. They show prominent nuclei and occasional nuclear groups. So now I would like to discuss what the literature says about granulosa cell tumors and related to the findings in our case. So granulosa cell tumor is a rare low-grade malignancy that occurs in the ovary. There are both adult and juvenile types. They originate from the ovarian granulosa cells, and they represent 70% of ovarian sex or stromal tumors, but only 2 to 5% of all ovarian malignancies. Approximately 25% of patients develop recurrence, and the median time is 6 to 8 years. But the disease may often recur even more than a decade after the diagnosis. And we saw that behavior in our case, where the tumor came back not only once, but twice after the initial diagnosis in 2006. Cytologically, granulosa cell tumors can show different patterns that include loose or tight aggregates, trabecula, microcini, and single cells. The most characteristic feature are the cold external bodies. However, they're only present in less than 50% of the cases. In our case, we were able to find those cold X-ray bodies. Here we have a picture from the DMA's book, but do you remember that liquid stain smear that showed those rosette-like arrangements? So those were those cold X-ray bodies. Additionally, the cells showed angular to oval nuclei, that coffee bean appearance, and naked nuclei that was also present in our case. Now I would like to touch briefly on inhibin B as a tumor marker. So inhibin B is a hormone that granulosa cells produce. And in patients with adult type granulosa cell tumor, they're going to have elevated levels of this hormone in serum. So it is considered a sensitive and a specific marker for adult type granulosa cell tumor of the ovary that may be used during follow-up for detection of recurrences. So in our case, this tumor marker was used. This graph is going to show the trend in inhibin B levels over time. So as we see in 2024, there was an elevation of 234, which correlates with tumor recurrence. And then it dropped to less than 4, which correlates with surgical resection and response of the tumor to treatment. And that's pretty much all I have for you today. These are the references that I used. And then I would like to acknowledge the cytopathology team at Nebraska Medicine, Dr. Lynn, Dr. Anna Jo Waldes, our cytopathologist, and Dr. Mukherjee, who's our program director. Thank you.